Fine, thank you. How are you?
Assalamu alaikum, everyone. Today we're going to start our Zoom meeting. So the Golf team will be presenting today. Dr. Naod will be the moderator, and we're going to pass it to you, Dr. Naod. When you have a minute, you can start. Thank you.
Okay, thank you, Dr. Naod. Can anyone hear me clearly?
Yes, we can, Dr. Naod.
Okay. Hi, everyone. So today we have 3 presentations and residency application mock interviews. So our first presentation is going to be about pulmonary disease in older adults. And the presentation will start with Dr. Shata. So the floor is yours. We can start the presentation.
Okay, thank you. Assalamu alaikum, everyone. Good afternoon and good evening, based on your location. Thank you, everyone, for attending this meeting. And as always, thank you, Dr. Nadir, for giving us this opportunity. Me and my colleague, Dr. Alaa, will be presenting a session about the pulmonary diseases. And we will focus more on the pulmonary diseases in elderly. Just give me 1 second to share my screen. Okay. I'm just having some issues, just a few seconds. Can everyone see my screen?
Yes, we can.
Okay. We will start this session to talk about the respiratory disorders and diseases, and we will focus more on these conditions in elderly population. Okay, our objectives on this session is at the end to know and understand how to evaluate common respiratory symptoms, especially dyspnea, chronic cough and wheezing. Also, we will be talking about the 5 A's for helping patients to quit smoking and how to recognize and treat major pulmonary diseases and disorders in all the patients. Also, the decision-making about mechanical ventilation at the end of life. The topics that will be covered today are the age-related pulmonary alterations, common respiratory complaints and symptoms, major pulmonary diseases in older persons, and the intensive care of the critically ill. We will start our talk about the age-related pulmonary alterations. So as we know, like our bodies change with the age. These changes are natural. They happen to most of us, or if not everyone. So some of the major age alterations that happens in the lungs mainly are reduced airway size and shallow alveolar sacs. And these two occur because of the age-related connective tissue atrophy and the connective tissue disease. Also, we have reduced chest wall compliance, which occurs due to kyphoscoliosis, calcification of the costal cartilage, and arthritic changes of the costovertebral joints. Also, we have intercostal muscle atrophy and reduction in the diaphragmatic strength. These two occur because of age-related sarcopenia, which is the age-related muscle weakness and atrophy. All these changes will result in the end in a reduction of the forced expiratory volume in 1 second for the patient, and also it will reduce the forced vital capacity. Usually we will see a picture similar to that seen on patients with restrictive lung disease. But these changes will be normal in elderly patients, and we should put them in consideration regarding when a patient presents to the clinic with respiratory symptoms. There are some challenges that we face in recognizing respiratory symptoms. One of these challenges is the common misperception that older people tend to overestimate or exaggerate the symptoms, while in fact the opposite is more often true. Older patients and their physicians tend to underestimate the importance of respiratory symptoms, especially dyspnea. It may go undiagnosed until advanced disease is evident. This is partially due to the fact that dyspnea is blamed on age and deconditioning. Also, older people often adjust their activity level to compensate for the symptoms, so they don't seek the health help regarding these symptoms. They just adjust for it and compensate. Such changes are significant, and we should educate the patients, their families, and the clinicians about these changes, because such minor changes, like if an elderly is not going out as he used to be, he's not moving as he used to be, this could be a sign of dyspnea. He's not moving because he's dyspneic, because moving 1 or 2 blocks will cause him dyspnea, but he will think that this is just because of age, and he will not mention it to you. Also, older people often have more than one explanation for their problems. Since dyspnea, cough, and wheezing, they may overlap, but the underlying causes are some of the major issues. It could be like asthma, emphysema, obstructive sleep apnea, heart failure, or GERD. We will be talking about one of the most common respiratory symptoms presentation, which is dyspnea. And the most common causes to be considered are COPD, cardiac disease, asthma, interstitial lung disease, and deconditioning. It does not necessarily correlate with oxygenation or the pulmonary function test. So the evaluation usually starts with a thorough history and physical examination, which can direct us into which test to be used. And sometimes we can start the management with just empirical treatments based on the history and the physical examination. Some of the things that might help us in diagnosing the condition is the word description by the patient themselves. Usually when a patient describes their condition or their dizziness as heaviness, it can imply a cardiac dysfunction or a deconditioning. But if the patient describes it as a tightness sensation, it may imply angina or asthma. In older patients presenting with a dyspnea associated with nocturnal cough, we can just consider the most common illnesses. Like usually we say in medicine, common is common. So we should always start thinking about the most common conditions: asthma, emphysema, allergic rhinitis, postnasal drip, and GERD. This consideration to minimize the extensive and invasive testing, we can just start with a simple clinic pulmonary function test and give the patient an empirical treatment depending on the history, on the examination, and the pulmonary function test findings. And then we can see the response of the patient, and according to the response, we can either prescribe the patient further medication or start the patient on like an invasive regimen of investigation. But we should always keep in mind like some red flags, some significant changes that from the beginning we should start with invasive investigation. For example, if the patient is presenting with a significant weight loss and constitutional symptoms like fever, night sweats, we should always consider malignancy and TB and start investigating for those diseases. Also, one of the common symptomatic presentations is chronic cough, which is cough presenting for more than 8 weeks. Usually the causes are benign. The most common are postnasal drip, asthma, GERD. Like I mentioned in the previous slide, it's always better to start the patient on a simple approach with the least invasive investigation and give the patient empirical treatment and see the response to these treatments. The postnasal drip, asthma, and GERD actually account for more than 90% of the causes of chronic cough, especially in the elderly population. But we should always keep in mind other differentials, like a medication side effect, like the use of ACE inhibitors. It can cause a chronic cough. If the patient has heart failure, they can present with chronic cough. We should also consider laryngeal dysfunction, pertussis infection, chronic cough due to a viral infection or a secondary to bacterial infection. We should also consider recurrent aspiration if the patient is having symptoms with reoccurrence, the patient is given the treatment and he resolves, all the symptoms resolve, and then they reoccur, especially if they are in a single area, in a determined area in the lung. We should always consider the idea of an obstruction and even the possibility of aspiration. Also, one of the common presentations is wheezing, and it's most commonly caused by asthma, postnasal drip, and COPD. Usually in the younger population, wheezing is associated with asthma, but in the older population, it's not the most common cause of wheezing. Usually it's COPD. Also, one of the causes that can cause wheezing in an elderly patient is what we call the cardiac asthma. If the patient has heart failure that results in a pulmonary edema, the patient can present to the clinic with wheezing. We should always keep in mind the air hyperresponsiveness from chronic bronchitis and COPD, especially if the patient has risk factor, if the patient is used to be a smoker, if the patient has occupational risk hazards, and so on. So these are the major pulmonary diseases in older patients. We have rhinosinusitis, asthma, COPD, obstructive sleep apnea, idiopathic pulmonary fibrosis, pulmonary thromboembolism, pneumonia, and lung cancer. We will be talking about most of these conditions on this session, except for pneumonia and lung cancer, which are covered in another session. So starting with rhinosinusitis, which is the inflammation of the paranasal sinuses and the nasal passage. It can be acute, subacute, or chronic. Acute presenting for just less than 4 weeks. The chronic is considered a presentation for more than 12 weeks, and the subacute is something in between. Just like the younger population, in the older population, the most common causes of rhinosinusitis is viral infection. And we treat it the same with just supportive care, nasal irrigation, and saline, okay, and analgesics. If we suspect a bacterial infection, we should also start with supportive care like analgesic, saline, irrigation, and antibiotic. An antibiotic only given if the patient has symptoms that lasted for more than 7 days, or if the patient's conditions worsens with time and the patient is not getting well, we can start the patient on antibiotic. Usually the start of antibiotic in early mild disease is not recommended because it will cause more harm to the patient than benefiting them. Also, we have chronic rhinosinusitis, which is treated with topical agents like decongestants, corticosteroids, and saline irrigation. We have allergic rhinosinusitis, which is treated by the avoidance of the inciting allergen, and we can use topical nasal steroids in those who do not improve with avoidance of the allergens. We will start our talk in asthma about the epidemiology of asthma. Usually after childhood, there is a second peak in the prevalence of asthma beyond the age of 65. The rate of deaths from asthma has increased most significantly in those 65 of age or more, which accounts for around 50% of all asthma deaths. It occurs in patients 65 years of age or more, which is a major health burden and significance. This high rate is likely due to the decreased awareness of bronchial obstruction from the patient, and that's why they will be delayed to be presenting to the clinic. And as well, from the clinician's point of view, the under-recognition and under-treatment will be a cause of this high mortality rate. For asthma treatment, we use inhaled corticosteroids and other controller drugs like leukotriene receptor antagonists as the mainstay of therapy. And as always, as we do in medicine, we start with the lowest effective dose, and we use the step-up approach to increase the dose to reach to the level of patient's comfort and the effective treatment with the lowest dose possible. Beta agonists are used as needed reliever medication only. They are not considered as controller medication, but the new guideline says that even for reliever medication, we should use the beta agonist in combination with the inhaled corticosteroids. We don't use the inhaled beta agonist alone like we used to do in the past, but now we have to use them in combination with inhaled corticosteroids. Also, one of the important aspects about asthma treatment is the instruction of the proper use of the peak expiratory flow monitoring, because usually elderly patients, they have under recognition of their bronchoconstriction. They don't get the symptoms as young people do. They don't get the perception of the symptoms as young people do. So we instruct the patient on the correct activation of the inhaler device, and we observe the patient actually using it. We counsel the patient on rinsing the oropharynx to avoid the thrush from the steroids. One of the options that can be used as a control medication is the thiophelline, but in elderly patients, they have a high risk profile. They cause many adverse effects and drug interactions, so they are not considered as a first or even a second line medication. We can use them as a third line medication in those with severe asthma or COPD, not responding to the first and second line medications. Also, we should keep in mind that beta agonists, they cause a lot of side effects, especially in elderly. They can cause hypokalemia, they can cause QT prolongation, especially if they are used with other medication that can prolong the QT interval. We should keep this in mind, and we should always try to minimize the dose and use the least effective dose possible. Here are some examples of the most commonly used inhaled medications. Like for beta agonists, we have albuterol, formoterol, and salmeterol. With corticosteroids, we have many options like beclomethasone, fluticasone, triamcinolone. Also, we have combination medications, in which medication we have inhaled corticosteroids and long-acting beta agonists. And nowadays, they are used very commonly because, like I said, using inhaled corticosteroid in combination with the beta agonist is now the mainstay of treatment for reliever and for controller medications. We have other options like mast cell stabilizers like cromolyn. We have ipratropium and tiotropium, which are muscarinic receptor antagonists. We have many other options, but the mainstay of treatment for asthma and COPD is mainly inhaled corticosteroids with beta agonists. We will talk about the COPD now. In the epidemiology of COPD affects about 15 million people in the US, and it's the fourth most common cause of death after heart failure, cancer, and stroke. The prevalence and mortality rates are increasing, especially in elderly patients. And the morbidity and mortality from COPD accounts for more than 15 billion per year in US medical expenditures, mainly due to hospitalizations. Patients presenting to the clinic with acute respiratory failure require mechanical ventilation. They have a very high rate of mortality rates. Elderly patients presenting with COPD and acute respiratory failure, they have a very high rate of mortality, which can rise up to 46 or 50%. How to diagnose COPD? The first thing that we need to establish in the diagnosis of COPD is the presence of airflow limitation. We have many predictors of the presence of airflow limitation, and wheezing is the best predictor for airflow limitation. We have other predictors like barrel-shaped chest, hyperresonance on percussion, and forced expiratory volume or forced expiratory time prolongation. Okay. To diagnose the airflow limitation, there are always some challenges because not a single item or a combination of items just from the history or clinical examination can exclude the presence or can confirm the presence of airflow limitation. So the next step usually we do pulmonary function test. We have the Global Initiative of Chronic Obstructive Lung Disease guidelines for COPD. We search for key factors to consider the diagnosis of COPD. These key factors are dyspnea, chronic cough, sputum production, and the presence of risk factors. The presence of any of these key factors should raise the suspicion for the presence of COPD, And then we should do the pulmonary function test, the spirometry, to confirm the presence of obstruction. To classify the patient as having COPD or having an obstructive lung disease, we need the forced expiratory volume in 1 second over the forced vital capacity ratio to be less than 70, which is the same for young people. In elderly, we have a minor exception in that people who are more than 70 years of age, some clinicians, they prefer to use the cutoff of 65, of having the ratio less than 65 to diagnose COPD, rather than it just being less than 70, because of the earlier alterations that we talked about in the earlier slides, that elderly people, they have age-related changes. These changes can result in the reduction of the forced expiratory volume and the forced vital capacity, rather than it being just from COPD. So in all patients more than 70, we should consider a lower cutoff to diagnose COPD. We need a ratio to be less than 65. Also, based on the forced expiratory volume in 1 second, we divide or classify the patients of COPD into mild, moderate, severe, and very severe. So if the patient has a forced expiratory volume in 1 second of 80% or more, this patient is considered to have a mild disease. For those who have a forced expiratory volume in 1 second less than 80 but more than 50, we consider them as moderate, and so on. This classification helps moderate COPD. Can everyone hear me? Because I think my connection is breaking.
Yes, we can hear you.
Okay.
Continue.
Okay, thank you. Okay, for moderate COPD, we use regular treatments with one or more bronchodilators like beta-2 agonists, ipratropium. We can use thiophyllene with caution. Also, one of the important aspects of the management of patients who have moderate, severe, or very severe COPD is the respiratory rehabilitation. Okay, patient will be given like certain exercises. They will be given some incentive spirometry to help them with the respiratory function. For the severe COPD, we use the regular treatment with the bronchodilators, and we add to it inhaled steroids, or if the symptoms are very significant, we can even give the patient oral steroids in the acute exacerbation. In the very severe COPD, also we start with the regular bronchodilators. We add the inhaled corticosteroids. Also, we can add options like thiophyllene. We can add muscarinic receptors antagonist, and so on. Other important interventions that we need to do for patients with COPD, we have the oxygen therapy. Like long-term oxygen therapy will benefit those who are with an arterial oxygen less than 55%. Those patients, if we give them a prolonged oxygen for like 15 hours per day or more, this will improve their survival, their exercise tolerance, their sleep, and even the cognitive function. Also, we give the patient exercise training, the respiratory therapy, and education. Also, the treatment for other comorbidities like depression and anxiety, since around 40% of COPD patients, they have psychiatric comorbidities like depression and anxiety, which will affect their use of treatment. It will affect their presentation to the clinic, and so on. Also, one of the common diseases in elderly, one of the common respiratory diseases in elderly is the obstructive sleep apnea. We should always have a high index of suspicion, especially in those with risk factors, those with high BMI, patients with snoring during sleep, patients who feel tired during the day and they don't get well rested during sleep. Obstructive sleep apnea is a life-threatening, okay, yet potentially correctable. It's usually associated in elderly with stroke, MI, and it has a 3-time increase in mortality rate in these patients. Sleep-related breathing disorders are very common in elderly people, and obstructive sleep apnea is the most common of these sleep-related disorders. What are the options for the treatment of sleep apnea? The first thing that we need to do to treat sleep apnea or obstructive sleep apnea is the weight loss, because weight loss accounts for the most significant risk factor resulting in sleep apnea. Also, avoidance of alcohol and sedatives can help. Sleeping on one side or being upright, the correction, sorry, of the metabolic disorders like hypothyroidism can help the patient. Also, one of the options that we can use is the use of continuous positive airway pressure via a nasal mask or a nasal cannula can also help the patient in these conditions. I would like also to talk about the smoking cessation, since we know smoking is one of the major risk factors of respiratory illnesses or even other organ illnesses. So we have this 5 A's approach to help the patient to quit smoking. The first thing, we ask the patient about the use of tobacco at every visit. Even if the patient is reluctant in the beginning, we should bring this subject on every office visit. Okay, we assess the readiness to quit smoking. We advise the patient to quit, and we assist the patient on the quitting attempt by giving him aids like local cessation program, pharmacological agents like bupropion, nicotine replacement therapy. Also, we should arrange for both a quit date and follow-up visit to discuss the quit attempt. Okay, thank you everyone. This is the end of my part. I think we can take questions or make it at the end of the presentation.
I think it's better if Dr. Alaa continue with the presentation, then we can take questions together for the whole.
Okay, good. Okay, good.
Yeah. Okay, thank you, Dr. Ali, for your presentation.
Yeah, my pleasure.
Good afternoon, everyone. This is Dr. Alaa Hassan. I'm going to continue in the presentation of Dr. Ali. Just 1 second. I'm going to share my screen now. Everyone can see my screen?
Yes, we can see a screen.
Okay. So we're gonna start talking about idiopathic pulmonary fibrosis, and it's relentlessly progressive. It's a progressive disease, and the median survival for the patient is 3 to 5 years. A normal presentation of it comes with insidious dyspnea. It's gonna be progressive dyspnea and cough. And this, the main thing that to differentiate between the pulmonary fibrosis and emphysema is the clumping. We have clumping is the prominent finding in fibrosis, pulmonary fibrosis. And it's commonly treated initially with oral corticosteroid, but only 10 to 20% of the patient gonna respond, and the adverse effect of it is really prominent. So early referral for subspecialist is warranted if the patient wishes to consider further therapy. It's going to be better than oral corticosteroid. So we're going to talk about pulmonary fibrosis, pulmonary embolism, sorry. The incidence is tripled from age 65 to age 90. This is a common thing. And age more than 70 is a risk factor for misdiagnosis. And the blood gases can be normal in 10 to 20% of the patient. And the diagnosis workup in the same as Niagara patient. We diagnose the pulmonary embolism by the Wells criteria for pulmonary embolism. We give 3 points for the clinical signs of DVT. And if the alternate diagnoses are less likely than the PE, and we give 1.5 points if they have previous PE or DVT and the heart rate was more than 100, and there is recent surgery or immobilization. Each one of them get 1.5 points. And we give 1 point for hemoptysis and cancer. If the score was more than 4 it means it's probable that it's going to be PE. If 4 or less, it's less probable to be PE. So it's diagnosed the same like younger patient. And 10% recurrence rate within 1 year. Anticoagulation is guided by the same principle also as the younger adult, and in older patient, it may be even more important to achieve the therapeutic level of heparinization quickly. So we have to give low molecular weight heparin while achieving the anticoagulation with warfarin. We're going to give both of them and wait until the warfarin work for 3 to 5 days. And also allow the overlap for 1 to 3 days between the heparinization, the low molecular weight, and the warfarin therapy until the INR target to 2 to 3. In most cases, the anticoagulation therapy should be continued for at least 6 months. Okay, now we're going to talk about the intensive care of the critically ill. The support study showed that the physician error rate is approximately patient preference for mechanical ventilation. If the patient less than 50 years, it's going to be 36% of the patient. And if it's more than 80 years, it's going to be increasing. It's going to be until 79% or something. So the physician should be more consistent in attempts to elicit the patient preference for the DNR orders, and the decision to use mechanical ventilation should not just based only on the age of the patient. Also, unlike the general medical ICU population, patients with ALI or ARDS appear to have higher mortality with advancing age, and ALI patients require twice as long to be liberated from the ventilator. They will take much longer time to take them from the ventilator. And the comorbidities often contribute to death in ALI. The main cause and death is from the comorbidities is coming with it. The cognitive decline often dramatically worsen after the ICU stay and become the major threat to quality of life. Going to be, they will have cognitive decline. So if we have here a study of 851 patients receiving mechanical ventilation, you're going to see 63 of them successfully liberated, and 17% they die while receiving the mechanical ventilation, and 20% they have mechanical ventilation withdrawal. So the AMA recommends that a standardized fair process rather than strict definition of fertility, and rather the chronological age alone, fertility decision should be based on other factors, such as the clinical efficacy of the treatment, is it effective or not, the likelihood of mortality, and the subsequent quality of life. So here we're going to talk about the summary of these things. With age, there is decline in forced vital capacity and forced expiratory volume in 1 second, and partial arterial O2. So this is also normal. Like my friend, Dr. Alaa, he said that the forced vital capacity, forced expiratory volume in 1 second, and partial arterial O2, they're going to be declining, and the AA gradient, they're going to be increased. And there is 5 to 10% of people age 65 and more meet the criteria for asthma, and smoking cessation may slow the decline in the lung functioning at any age. At any age, the smoking cessation is better. And also, most patients with COPD derive little or no benefit from routine inhaled corticosteroid, but a brief course of systemic corticosteroid may reduce the duration of the acute exacerbation. So we don't care about the routine inhaled corticosteroid, but rather the systemic one. It's going to be better for reducing the duration for acute exacerbation. Older people recover the pulmonary physiology the same rate with a younger cohort, but some diseases state that they may require longer time to be liberated from the ventilator. Like I said before, they will take longer time from the ventilator. But as the physiology is going to be the older and younger is going to be the same. So we will have some clinical practices, and we're gonna have some cases. I'm gonna see your answer about it. So everyone be ready. 72 years old man come to the office for evaluation of dyspnea that has progressed slowly over 6 years. He has COPD and has used albuterol as needed for 6 years. He has a daily non-productive cough and wheezes intermittently. He can no longer participate in activities such as golf. 6 months ago, he has exacerbation of COPD requiring prednisone. He has never been hospitalized or gone to the emergency room. He quit smoking 3 months ago. On examination, temperature is 36 Celsius and blood pressure is 145/85. Heart rate is 96 beats per minute and respiratory rate is 22 breaths per minute. There is no accessory muscle use. Bibasilar crackers are audible and exhalation is slightly prolonged. Cardiac examination is normal. There is trace ankle edema, but no cyanosis or clubbing. Oxygen saturation on room air is 93%, and chest radiography displays hyperinflated lung. The pulmonary function test, we have the forced vital capacity is 85, and forced expiratory volume in 1 second is 60%, and the ratio is 60%. After treatment with bronchodilator, forced expiratory volume increases by 11%, and forced vital capacity increases by 10%. So, in addition to continuing the albuterol as needed, which of the following is the most appropriate treatment at this time? It's going to be albuterol, ipratropium pomade, albuterol ipratropium, or tiotropium, or inhaled corticosteroid. Can anyone answer in the chat, please? I'm going to give you 15 seconds. A, B, C, D, E. Okay. So the answer is going to be tiotropium. I'm going to give muscarinic antagonist, D. So next, we're going to have a next scenario here. 75 years old man is evaluated because he has sudden onset of shortness of breath, sharp pleuritic left side chest pain, and a cough productive of a blood-tinged sputum. He has elective hip replacement surgery 6 days ago. He has been and is wearing pneumatic compression device on both legs. He has 20-year history of COPD, and he is taking a proton pump inhibitor for a duodenal ulcer diagnosed 2 weeks ago, and albuterol as needed. Temperature is 38, blood pressure is 165/90, heart rate is 110, and respiratory rate is 26 per minute. So there is no accessory muscle use. The patient has slight expiratory wheeze, and there is no GVD. A left side S4 gallop is audible, and the abdomen is soft without masses or hepatosplenomegaly. There is no cyanosis, clumping, edema, or thigh or calf pain. WBCs is 13,800 with 85% polymorph nuclear cells and 6% band. On ELISA, the D-dimer was less than 500. The ABG's pH, we have 7.48, and the partial arterial O2 is 70 millimeter mercury, and the partial arterial CO2 is 30, and ECG reveals sinus tachycardia. Chest radiography reveals left lower loop atelectasis or infiltrate, and the VQ scan indicate low probability for pulmonary embolism. Bilateral lower extremity Doppler ultrasonography demonstrate no evidence of DVT. So which of the following is the most appropriate next step? It's going to be treat with heparin, place an inferior vena cava filter, treat with antibiotic and steroid, obtain CT of the chest, obtain CT angiography of chest. I'm going to give you another 15 seconds. Okay, everyone. So the answer is going to be obtain CT angiography of the chest to make sure that it is PE. Okay, we have the last scenario here. A 70 years old retired mailman come to the office because he now has difficulty climbing one flight of stairs. He has dyspnea on exertion that has progressed slowly over 5 years. He wheezes occasionally and he has had a minimally productive morning, cough for many years, but no chest pain or discomfort. He has a 50-pack year cigarette smoking history and still smokes. Temperature is 36 Celsius and the blood pressure is 115/75 and the heart rate is 98. Respiratory rate is 22 breath per minute. There is no accessory muscle use. Bilateral crackles are audible and cardiac and abdominal examination are normal. There is trace peripheral edema and mild clumping but no cyanosis. Chest radiography is normal and the pulmonary function test. Forced vital capacity is 65%. Forced expiratory volume in 1 second is 70, and for the ratio for them is 75. After bronchodilation, the forced expiratory volume in 1 second increases by 9%, and the forced vital increases by 8%. Which of the following is the most likely cause of this patient dyspnea? Is it asthma, COPD, idiopathic pulmonary fibrosis, pleural effusion, or pulmonary embolism? Come on, everyone. Want your answer in the chat, please. All right. I think everyone got this one right. This is idiopathic pulmonary fibrosis. And that's it. This will be the end of our presentation. Everyone, thank you.
Thank you, Dr. Ali Muhammad and Dr. Alaa for the nice presentation on different pulmonary presentations, especially in other Arabs. So both of our colleagues were given us about the basic and straightforward presentation, as well as confused or maybe interrelated presentation of different pulmonary diseases. So if you have any question, either for Dr. Ali or for Dr. Alaa, you can ask now.
I have a question.
Okay, go ahead, Dr. Dana.
Thank you, Dr. Alaa and Dr. Ali. I have a question for Dr. Alaa for the second case. Could you please explain why should we do the CTA for this patient?
Okay, you're talking about the second case. Yeah, the PE case. Okay, the PE case, he was a 75 years old man and he has tachycardia.
You can share the screen. Maybe it will be easy
Everything.
to see the.
Okay.
Yeah.
Just a second. Is it appearing for everyone?
Yes.
Yeah.
Okay. This case of a 75 years old man, he was having sudden onset shortness of breath, and they have the sharp pleuritic chest pain and everything, and he has COPD. He has high temperature and he has tachycardia and everything. And then when they do the D-dimer, it was less than 500. And here with the VQ scan, it indicates low probability for pulmonary embolism. So we're still confused because all this test is given negative thing. So we have to make sure and do the CT angiography of the chest is going to be appearing the pulmonary embolism and the closing it.
Does that
All right.
answer the question,
Thank you.
Dr. Did you get it? Did you get your answer?
Yeah, thank you. Thank you so
You're
much.
welcome.
Anyone, if you have any more questions, the floor is yours. Okay, if nobody has a question, we'll proceed to the second part of the presentation, which is how to write to an editor of JAMA or the NEJM, and it will be presented by Dr. Zuba. If she, you can share your screen if you are ready.
Okay. Hello, everyone. Good afternoon. My name is Zeinab Muhammad, and I will present the letter to the editor. But first, I would like to thank you, Dr. Nader, for giving me this opportunity. So, can everybody see the screen?
Yes, we can.
Okay. So, first thing is that what is a letter to the editor? It's a brief communication to a journal's editor or editorial team, and it's usually written in response to a recent publication within the journal. And it can also be on an unrelated topic of interest of the journal's readership. My screen is not moving. Okay, sorry. So now let's move to the purpose of the letter to the editor. There are many reasons to write a letter to the editor in medical field. Commenting on a recently published article is the common reason for writing a letter to the editor. These letters may ask important questions of author's published paper, as example, requesting clarification about the content of an article or requesting additional analysis or data. And also as a provide alternative viewpoints and list criticism about the article. And another reason is the letter to the editor are considered for publication, that it's provided they do not contain materials that has been submitted or published elsewhere. So the letter are subjected to editing and abridgment. There is things to do and others to not do or to avoid in letter to the editor. So the things which must be done to be mindful of rules and dates, and to watch your words count, and to be relevant and deliver clear message. And other thing, your letter should be structured and easy to read, and back up your points with evidence. And the things that it must be avoided to be irrelevant or outdated, and there is no need to write a letter if there is no added value. Another thing, to not be hypercritical or aggressive. Another thing is to avoid bias. There is, you can make a work plan in 4 steps to write a letter. First thing, read the topic and article, and the second thing is literature review and journal requirements and co-authors. And the third thing is writing. So you need to focus, follow the rules, and to be respectful in your writing. And the last step is submission. Let us talk about these points in separate. So about reading, you need to fully read and understand the topic or the article and think if the letter to the editor is needed or not. Other thing is to read or to point the strengths and the weakness and the controversies of the published thing. The last thing is ensure that this has not been misinterpreted. About the planning, undertake extensive literature research to gain wider understanding and determine any novel angle for your letter, and ensure that letter to editor is accepted by the journal. Okay, so we need to browse recently published letter to gain insight into the formatting quality and style expected from the journal. And think of potential co-authors to collaborate with. So usually up to 3 to 5 authors according to the journal. Co-authors should be identified early and should contribute enough to satisfy the co-authorship criteria laid out by the International Committee of Medical Journal Editors. So let us talk about the journal guidelines on letter to the editor. We need to be familiarized ourselves with manuscript submission guidelines, which are usually found under the information for author section of the journal website. This may also yield useful information such as limit on word count and the maximum number of permissible figures and tables and references, which will serve to frame the letter. Okay, now in writing, first thing within the opening paragraph, salutation to the letter to editor is optional, but may erode into the limited word count. So I think it's better to be avoided. And the second thing, avoid starting with dear sir, and if it's necessary, it's better to use dear editor. And the third thing, introduce the purpose of the letter to the editor early on. And the last and fourth thing is clearly mention the paper in question and provide a citation to the original paper. In writing, focus and brevity and flow are the key points to make a successful letter to the editor. Consider drafting in bullet point format to summarize key points, but write the letter in clear, focused sentences. Aim to limit the points raised, as example, to maximum of 3 to 4 points, depending on journal's words. And consider structuring the letter by allocating on paragraph to each key point highlighted, but avoid using subheadings. The introduction in the beginning and the key point paragraph in the middle and the final paragraph in the end should be waved together to ensure flow while maintaining a respectful tone of writing throughout. About citation, ensure that relevant references are correctly cited and up to date. and that the manuscript complies with the journal's requirements. Cite the literature appropriately using the latest and most relevant references, and avoid citing your own work excessively, as the letter to editor are not a self-promotion exercise. The summary is the final paragraph and should provide a concise summary and end with suggestion or future recommendations. Submission is the final step in the writing the letter. So letter to the editor should be proofread multiple times and approved by all co-authors before submission. This is a guideline for New England Journal Medicine. The letter in reference of a journal article must not exceed 175 words, excluding the reference, and must be received within just 3 weeks after publication of the article. Letters not related to journal article must not exceed 400 words. A letter can have no more than 5 references and 1 figure or table. A letter can be signed by no more than 3 authors. Financial association or other possible conflicts of interest must be disclosed, and the disclosure will be published with the letter. Include your full mailing address, telephone number, fax number, and email address with your letter. All letters must be submitted through online submission system at NEJM.org. And about JAMA, a letter discussing a recent article journal should be submitted within 4 weeks of publication of an article in print. So differ from New England that in 3 weeks. Letters should not exceed 400 words, as same as New England of text, and 5 reference, but 1 which should be the recent article. And as same as New England, letter may have no more than 3 authors. So final point about letter to editor is it should be written to deliver objective and constructive comments on published articles, and they should be brief and conclusive. And that is the end. Thank you. And if there is any comments or question.
Thank you, Dr. Zeinab, for the nice presentation on how to write a letter to an editor. One thing to add is just when you write a letter to any form of journal or editor, at the end of the day, the content should be precise and the word count should be small. And it usually should be straight to the point, because unlike other letters you write to your family member or friends, the content doesn't necessarily have to be explained in a very long paragraph. So usually it's like one of those writing exam you take in OET, which have a specific structure like an address to whom you are writing, the reason why you are writing, and you have to make your point clear and brief in small sentences and few words. And at the end of the day, it has to be like a formal letter saying sincerely Mr. or Mrs. Or if they have a title PhD or MD, making it look like the letter is more formal rather than personal. Apart from that, it's a very nice presentation. If any one of you have a question, the floor is yours. Any question is welcome.
Excellent presentation. Thank you so much, all of you. And, excellent.
If there is no question, we'll proceed to the third part of the presentation, which is about EndNote reference topic, and it will be presented by Dr. Ahmed Osman. So you can share your screen now.
Okay, hello everyone. Just a minute. Okay, is that visible for everyone?
Yes, it is visible.
All right, thank you everyone for being here. I'll be presenting about EndNote, which is it's a tool basically that's used as a reference manager. Now you have it available in Windows and Mac. Fortunately, it does require a paid subscription, but they do have a 30-day free trial. So if you have the time, try to finish your work in 30 days. Otherwise, you have to pay for the subscription. If you do register through your university email, it can be for free, just depending on the university, whether they're subscribed to it. So the prices for the full license is approximately $342, and there's a discount for the student license as well. So it's a very useful tool. There's several ways that you can add references. You can either add it manually yourself, or you can go through a web browser through online research. You can also download a reference file through the internet, or there's also an EndNote extension on your browser. So I'll just be giving a quick demonstration of how to use the program itself. Can everyone see it over here?
Yes, yes, we can.
Okay, so it's, as you can see here, it's pretty straightforward. You have your windows over here, so you have your menu where you have all your references, and you can also subdivide it into groups. So whether you're researching on a particular disease, you can subdivide it. So we said that there's several ways that you can add references. So I'll go through the first one, where you can manually add it yourself. So you go over here to the plus sign and you click on it, and that brings you to this menu over here. So you just add in the information. So the author's name, the year, the title of the study, the journal, the issue. Try to put in as much information as you can so that it can be found. And then once you put in all your information, you click on save over here. And then if the program can find it for you, it's added directly to your library. So that's one of the ways. The second way is through the online search. So if you look over here in the menu, you can see PubMed, Library of Congress, Web of Science. But there's also other options. So what you do is just click on the plus sign over here, and it gives you all these options for whatever resource that you're using. It's also a couple of university websites and everything. So you pick it and you choose it. So for this one, we'll just, for example, we'll use PubMed. So over here in the, as you can see here in the screen, you put in the author's name, put in the year and the title, and you click on search. So for example, we'll just do a quick one. I put it like this and click on search. And then it searches through the PubMed database, and then you get all the ones that come up with that name. So if you want to add it, you just click on it over here on the tick, and then you click on add, and that adds it to your references. Now, another option, which I'll just show you quickly through the web browser, is you go, so let's say you're here in PubMed, you open the website, and you have research here, for example. So this is an abstract over here. So let's say that you want to add this one to your references as well. So what you do is you click on send to, and then you go to citation manager and create file, and this downloads it. And once it's downloaded, you click on show folder and just quickly double click it. And then that study is imported over here to your EndNote program, as you can see just over here. Also, another thing to note is that you have your references, so all of them over here. Another cool option is that you can also add a PDF to your reference. So as you can see all over here, this one has a clipboard icon. So this shows that you have the PDF for the study itself. So you can open up the whole study over here on the side. Now for these ones that don't have a clipboard, so what you can do is you can either download it online and then click over here on attach PDF. Another option is you can right click on the study that you want, and then you can click on find full text. So unfortunately, sometimes this doesn't work. It depends on whether the research author made this open access, basically. but I think we got lucky with this one. We found it. So here's a study, whole study over here. And another option that you can use is, so I'll just quickly show you how to use it on Microsoft Word as well. Just a second. Sorry, this computer's gonna get stuck. So I'll just open up Microsoft Word over here. So you have Microsoft Word. So once you download the application and you install it on your computer, it should appear over here and the EndNote 21. So these are the options that you have. So if you want to insert a citation, you click on this over here and then insert citation. And then it shows you to your library. So we'll pick this one. And you click on insert, and then this shows up like this. So that's your citation. And then another option that you can do is, for example, let's say you think this is too long and you want it to be just a short one. So what you do is you click on edit and manage citations, and then edit reference. And then it brings you back to the program. So you just pick the information over here on the side that you want. So what you do is you scroll down, and then you can take out some information that you want or just the parts that you need. So we'll just take this paragraph out, and then you click on save. And then once that's done, you go back to Microsoft Word, and once you click on the citation that I just showed, you get the shorter part. And yeah, so there it is. And also just another option is that you can, like I said earlier, you can make it into groups. So you can add over here as well. And then if you imported anything from the web browser, you'll find that everything that's over here as well. Now, I apologize, this was a quick introduction to it, but if there's any questions, I'm more than happy to answer it. And I'm also going to add a link to a video, which also shows a bit more detail. This is just sort of a quick introduction on how to use the program. That's everything. Does anyone have any questions?
Thank you, Doctor, for showing us about the basic introduction to EndNote. If any one of you have a question, Doctor will be more than willing to answer a question. Even if you have a question from the previous presentation, before we continue to our next segment of this Zoom meeting.
Okay, looks like there's no questions. Thank you, everyone, for your time. I'll also be sending in the WhatsApp group an introduction video as well, just for gives you sort of more tips on how to use the program. Thank you very much.
Okay, thank you. Thank you very much, Doctor. So our next segment is about the mock interview for residency application. Before I jump to that, I will give you one slide on the tips of what to do and what not to do. I will try to touch on the subjects which were not presented in the previous last Saturday meeting, so that it will have a good input to the group as a whole. The original idea was to prepare a hypothetical candidate which will represent most of the people in this group, because most of us in this group are INGs, and almost more than half of us are by definition considered all graduate, because our year of graduation is greater than 5 years. So the original plan was to prepare that candidate, but unfortunately Dr. Farah come, actually, fortunately enough, Dr. Farah come with an idea because it will be hard enough to fit all the parameters of our group into one person. So we decided to do 2 short interviews of minimum 7 up to 10 minutes. And Dr. Dana and Dr. Farah were kind enough to send me their real CV. So I haven't told them what the questions that I'm going to ask to them. And at the same time, I just went through the CV and I have prepared a few questions. And at the end of the segment, you, the audience, can rate the candidates' interview skills and also my skills, and we can discuss on that. So I will share my screen now to show you. Can you see my screen?
Yes, we can, Dr. Naod.
Okay. So in this one page, I'll try to touch every topic that we need to do in residency interview. The first question is, what does residency program director say? So by definition, if at some point you got a chance of to be interviewed for a position as a resident, which means you have ticked all the boxes to be considered a potential candidate. So the next step is most probably going to depend on how you perform in the interview. So at some point, if you got a chance to be interviewed, your whole focus should be on how to perform as an interviewee in the real thing and show what you can prove or what you can provide to the program. So the interview is probably more focused on the content-wise and how you sell yourself to the program director, because they have already went all the content matter of your CV. So it's just how you sell yourself or how you present yourself to the director. Most of the common questions that is thrown at you is, why us? Why did you choose us? One, and secondly, why this program? So in this why this program, we may have like categorical programs or preliminary programs or research fellow positions. So go to the interview thinking that this is a definite question that will show up in your interview. Why did you choose this program? According to what kind of program you have chosen, either it's a categorical, preliminary, or research position, you should have a very definitive, clear, and to the point answer. And the third one is about specialty. They will ask you, why did you choose internal medicine? Why did you choose neurology? Or why did you choose emergency medicine? So you should also show up at the interview with a specific answer for a specific specialty. The content-wise of the interview may be facts versus reasons. So in the fact questions, they will ask you fact issues about your CV. For example, if you say, I have worked on 10 research papers, they can randomly pick one research paper and ask you, what was the role of you in this paper? How did you collect the data? When did the paper got published? So this is called a fact question, which means you have to know your material, whatever points you include in your CV, you have to know your material. And sometimes these fact questions may be a cross-checking or assessing whether how you really know your CV. And sometimes the questions may be directed as a reason. For example, if you switch a specialty from internal medicine to family medicine, or if you were a resident in your home country and decided to do the residency all over again, you will be asked about why. These questions are reasons. So reason question has to be personalized on a personal basis because they will not represent the whole group of applicants. So this is entirely about you. And the next one is cross-checking. This is very important. Sometimes you may include some data in your CV that you actually didn't do, which I personally advise not to do so. So sometimes you say you include observation program in 3 hospitals. You did observation for about 4 months or 6 months in 3 hospitals. So the program director may casually cross-check you by saying or asking, what did you do in this program? What did you do in this observation? I do have a personal experience of this one. A friend of mine actually included an observation program in his CV, but he also included the fact he was doing a physical examination. So some programs, as an observer, you are not allowed to touch a patient. if you put in your CV saying that I have examined a patient and observation program, that might raise some eyebrows in other residency program directors' idea of you as a candidate. So usually make sure whatever you put in your CV and whatever you say in the interview has to be facts. And the next one is red flags. Either we like it or not, at some point, all of us have a red flag. It has to be either year of graduation, low score, failed attempt, or been too many years away from your practice, or not having a research, not having a good clinical experience. So in terms of red flags, the best way to address red flags is not to moan about or not to make excuses, but you have to answer in a such a way that you made an extra effort to correct or to improve on that red flag. Other way of assessment in the interview is the personality. This is especially important for those of you who are going to apply to emergency medicine. The applicant and the residency program director who is going to interview sometimes may put this into a great perspective, because, for example, in emergency medicine, the candidate will be evaluated whether he is a good fit or a good person to spend maybe 8 or 12 hours uninterrupted in a hospital setting. So when you answer these questions, you will not directly say that I have a great personality or I have friendly personality. You kind of like work on it and explain it in such a way that the director will pick it up. Okay, this person, I could spend maybe 10 or 12 hours with him and I will not have any problem with him working in a hospital. So try to be as friendly, but not rigid. Also try to be also conservative. Try to balance out saying that you will be the kind of person to work with, but at the same time, who knows or who she knows her border. The next one is familiarity. Familiarity may be with the system, with the program, with the US medical system, or with the specialty. And this question may be thrown at you in different angle, saying that if, for example, if in your CV included, I have worked in electro medical record system for about a year, and 1 or 2 questions may pop out saying that, what do you do if you do this task? What will happen? So your ability to familiarize to whatever task you have put onto your CV is also very important. And the next one is interview with the golden rules. First, show up on time, whether it's in person or via webcam. You have to show up on time, 1. Secondly, you have to dress up properly for the occasion. You cannot show up dressing casually, because this is like an interview that will eventually determine your future life. And third one is try not to look too nervous and too rigid. Try to sell yourself as a kind of person who is confident enough to apply for that position. And also in interview day, try not to make sensitive jokes or sensitive comments, for example, about religion, culture, food, sexual orientation, or other personal issues, either from your end or from the other end. So try to be as formal as you can. And other things to add is what I call the imprints. So at some point in the middle of the interview or at the end of the interview, the program director may throw a question at you saying that, well, why do you think we should hire you? Or what tasks or what kind of achievement have you done that makes you a better candidate as compared to other people? So you can sell this point in different way. For example, in this group, we have 3 or 4 people who can do tasks that most of us cannot do. So, for example, we have Dr. Amal here in the group, which is good at doing app. So you will not make the whole interview about a specific task that you can do, but other people cannot do, but kind of highlight or drag the interviewer to that question so that they will say, okay, this guy or this girl we can hire as a residency candidate, and it can work good with us. But you cannot make all the interview about a single thing that you have done that will make you a better candidate than other people. This really helps you, especially if they won't remember you or rank you. So when they see the CV, you may have a good score or good clinical experience, research, publication. But at some point, if you formed an imprint in the director that will not be forgotten easily. That might help you get the position that you are applying for. So sometimes it's good to sell yourself or to proactively highlight things. They might be minor, but things that you have done that makes you a better candidate as compared to other people. So, and the last one is mistakes not to do at the interview day is just one, show up on time, as I said. And secondly, don't make insensitive jokes and don't make informal language saying that what up, man, or like something that might seem a bit strange to the candidate because you don't to the interviewer, because they don't personally know you. Whatever impression they are going to make on you will definitely depend on the 30 minutes or 45 minutes of interview they do with you. So watch out for those things. And also, even after the interview, try to reach out to programs saying that you are very thankful for what you have given, what you have been given the opportunity to be interviewed for a specific residency position. So I think Dr. Dana and Farah are in the group, right?
Yes, we are.
Okay.
Yeah.
Okay, good. So what we will do is just, we will start with Dr. Dana. Dr. Dana has sent me her personal CV. And after, at the end of the interview, you guys can rate the skill of the interview, either me or her, and you can give us either different kinds of comment or constructive comment on how to improve. So I will switch on my video. Can you see me?
Yes, we can. Yep. Yeah, we can see you.
Let me unshare the screen. Give me 1 second. Dr. Nadia, can you be the host so that I can share my screen and unshare my screen?
What did you say, Dr. Naod?
Can you be the host so that we can only share the videos?
You can share the video. I can make you the host.
No, I want you to be the host so that I don't want to share my personal screen on the. I wanted to unshare this one. Okay.
Is that better?
Yeah, that's better. Can you see my video?
Yes.
Okay.
Okay.
Dr. Dana, can you switch on your video?
Yeah. Can you see me?
Can you guys see her?
Yes.
Okay. So we'll start the interview. First of foremost, Dr. Dana, thank you for applying to this neurology residency program at the California Healthcare University System. First, can you tell me your full name? Where are you from originally?
Yeah. First, thank you for giving me this opportunity to interview with you. My name is Dana Ahmed. I graduated from medical school in Jordan. I graduated in 2019. And now I live in the US in Oregon.
That's nice. So you are originally from Jordan, right?
Yeah.
Yeah. Okay. Okay. Good. So you are applying for this neurology residency program, right?
Yep.
What makes you decide to join a neurology residency program at first place?
Yeah. So It's actually started when I was in the medical school, when I took the basic science of neurology. I was so impressed by how this basic of neuroscience is important in everything. Like understanding this neuroscience is very important in understanding the disease that we will treat in the future, and also how neurology is very interesting, and how it's linked to the physiology. And I like physiology. I like to understand the disease before treated. So yeah, it all began at that time, and it's like my passion actually.
Oh, that's nice. That's really nice. I see that you graduated in 2019, right?
Yeah.
From Jordana Medical School, right?
Uh-huh.
That is nice. That is nice. So what have you been doing after graduation the last 4 years actually?
So yeah, actually, after graduation, I had to do internship here in Jordan for about 1 year. I did it in the actually one of the most bigger hospital in Jordan, community hospital in Jordan, where I made many rotations, including in neurology. After that, I got married and I came to the US, where I had the opportunity to do many training, including observership in inpatient and outpatient clinic. So one of my training was outpatient in neurology clinic with Dr. Noah Gilson. Other training was with sleep medicine specialty, because for me, actually, I want to do sleep medicine fellowship after neuro residency. And this year, I also did inpatient training for neurology. It was actually observership, but I did it for about 1.5 months, and it was really good for me. I learned a lot from the doctor there. Also, during these years, actually, I returned back to Jordan and worked for about half year as a general practitioner, where I did many rotations and inpatient job there. And now, actually, I'm planning to do. I started to do inpatient internal medicine training, because I believe that both internal medicine and neurology are inseparable, and they both share many diseases together. Yeah.
That's really, really nice. First of all, thank you for giving me this extensive explanation on your clinical experience, and congratulations for getting married. I have seen in your CV you did 3 observations in the US, 1 in sleep clinic and other in neurology. Can you briefly explain what did you learn from these experiences as compared to your medical school back at home?
Yeah. So, because mainly in school, we had to read books and to save many disease and complaints or something. But in clinical training, it's a little bit different, especially here, because, the varieties of the disease and the diversity of patients. So I had to learn how to do examination. Although I did observership, but I also did training. So I learned from the doctor how to do examination for many diseases, for the peripheral diseases, and also for the central and cranial nerves diseases. And I also learned a lot about the medication that we use here in the US, because a little bit it's different from the medication in Jordan. And how to proceed with the patient from the first time that you see, and how to follow up with this patient, and how to know about them, how to do to interact with them, to do sympathy with them. So I actually had a lot to learn here.
Yeah, actually you are right, because here in the US we use brand name rather than the generic name sometimes. So there's a confusion about the different drug system. But
Exactly.
I like the fact you did observership in sleep medicine in New Jersey. That really goes with this program that you are applying for the neurology residency program. So coming back to this program, what makes you a good fit for this neurology as compared to other applicants?
So yeah, actually, I believe that I'm a good worker, and because I really want to be a neurologist, that's why I'm gonna do my best to be a good neurologist and to be a good candidate. I will work with my team and with my colleague and also because as I told you, I want to do sleep medicine fellowship. That's why I want to do more research about this. And neurology actually is my passion. That's why I'm gonna do all my best to be really good neurologist.
Good to have you here. Speaking of fellowship, I also see in your CV that you joined a geriatric research fellowship from Michigan, right?
Yeah, exactly. And it was really good opportunity for me because, you know, it's geriatric and we took many neurology lessons there with our course. Yeah.
Do you have any publications yet, or?
Oh, not yet actually, but yeah, I'm trying to do one. Yeah.
Okay, that is nice. That is nice. So the program that you are applying now have a cut-off year of 3 years for residency applicants. But it's good the fact that you still are in touch with your clinical experiences starting in 2019. Tell me something about yourself that you think have as a good quality as compared to other people.
Well, I think that my personality, I'm the one who, if wants something, I can do whatever to do or whenever I have to do to have this something. That's why I'm applying for neurology, even though that I've been graduated from 5 years for 5 years, but still actually. I mean, I graduated 5 years ago, but I still know that neurology is my passion, but I want to do neurology residency. That's why I'm gonna do all my best to reach my my dream and to be good one there. Yeah.
It's good to have you. I also see that you have 2 awards. Can you talk a little bit about them?
I'm sorry, I didn't hear the question.
You have mentioned you got 2 awards in your CV. Can you elaborate more on them?
Yeah. So yeah, during my medical school, actually, during my 3rd and 5th year, I got awards because I was a second. You know, I was the second one in my colleague and in my medical school. I got award from my medical school because of my high achievement there.
Oh, that is good. Congratulations on the achievement. So to give you a little bit summary of our program, we are very happy to have you and to consider you as a candidate. Our program is a neurology residency program. And even though our cut point is 3 years, we will still consider you as a candidate. And one more thing to ask about is just, do you still require visa to join our program, or?
So no, actually, because now I'm actually in the bit of processing to have a work permit. I have a visa now, but you know, I applied for a work permit, which gonna be ready in about 1 or 2 months.
Oh, good, good. So I think this is the preliminary question I have for you. If you have any questions for me, you are more than welcome to ask.
Well, thank you for interviewing me. My question is, could you, in point of view for you as a program director, could you tell me more about the relationship between the residents at your program?
So our program, we do have senior residents and the junior residents. So the relationship, how it works is the primary program director will first-hand observe you for the first year, and you will be under direct supervision of the senior residents, especially for the first year. I think the first year is going to be a bit tough and challenging in order for you to incorporate, but our program is very helpful. By second year, we will be in a position where you will eventually guide and help other candidates. So I think you will love it here and you will enjoy it working with us.
Thank you for letting me know. And other question, actually, it's not a question. It's like I want to ask you to give us as an advice for us as a new intern or new resident.
Well, at some point we all were residents, so key point is communication. You have to know how to communicate well to get your point across to people, whether at work or social gathering with your colleagues or with your residents, friends, one. And secondly is try to forget whatever happened during the shift hours. And when you go out of the hospital, whatever good or bad happened, try to forget in the hospital. I don't want you to stress out, especially the first year. So when you go out to the hospital, try to enjoy life as much as you can, one. And secondly, everyone is very helpful. They are very helpful, especially the new residents and the old residents. Most of them are very helpful. And third one is this program will also enrich you in your pursuit of neurology as a primary specialization, considering you have worked a lot on that. And we are also welcoming to different cultural diversity, so you will love it here.
Well, thank you. Sounds wonderful. Thank you so much.
Okay. So guys, the interview ends here. We are open to criticism, ideas, and different comments. Can you hear us, guys?
Yes, we did. We did hear you. Thank you, guys, both.
Dr. Nadir, any room for comment?
Give me a second.
Okay.
Hello?
Hello?
Yeah, hello. Sorry. Great job. So we will go to the next and then we will give feedback.
Okay. So for the next interview, we will interview Dr. Farah, who is applying for internal medicine residency program. I will try to ask not the questions that I have asked previously to Dr. Dana. I will ask something different. And on top of that, because she's applying for internal medicine and her CV is completely different, so it will be a different interview. You can see my video, right?
Yes.
Dr. Farah, can you turn on the video?
Hello, everyone. Thank you.
Can you see her, guys? Hi,
Yes.
Dr. Hi, Dr. Farah. First of all, welcome to this interview. You are applying for an internal medicine residency program in Michigan. Can you tell me your full name and your year of graduation first, please?
Hello, first of all, and thank you for having me here today in this interview. My name is Farah. I'm Dr. Ahmed. I graduated in 2019 from the National University of Sudan. And
Guys, can you hear her clearly?
No, we can't hear Dr. Farah clearly.
So okay, let's give her 1 minute to reconnect her internet.
no problem.
Can you hear her now? It's okay if the connection is taking your bandwidth is because you are turning on the video. You can turn off the video and continue on audio if it's a problem for you.
Can you hear me?
Yes, we can hear you.
Okay, I'll try opening my camera again.
Okay.
Can you see me?
Guys, can you see her?
Yes, we can see her.
Sorry for the interruption. So yes, I was looking through your CV and you graduated in 2019 and you are originally from Sudan, right?
Yes, that's right.
You have very impressive CV. So before we start the interview, feel free if you feel to ask a question at the end of the interview, but we will go through basic interview with you. And I hope you will enjoy the interview and good luck, okay?
Sure.
One thing that really impressed me about you is just you did an internal medicine resident as well as ophthalmology resident in Sudan, right?
Yes, that's right.
Yeah. Why did you do that? Internal medicine and ophthalmology, two completely different specialty.
That's right. So what happened is I finished my internship in my home country, Sudan. And then there's something called the National Compulsory Service, which you have to do in your country, in my country. And sometimes you don't get to pick what you want to do. So at that time, that one position that was open and sensible in terms of transport and much more closer to my home was actually that ophthalmology spot in that specific hospital. So I had to take it. But it was actually a really beautiful experience that what allowed me to actually solidify my choice of a specialty. I got to actually, because during my internship, I got to do an this rotation, surgical rotation, a pediatric rotation, and an obs and gynae rotation. That's the system in our country. I couldn't do a subspecialty at that point. So actually having the opportunity to go about and do something different, after looking back to it, I'm actually grateful for the experience, because I was sure now that this is what I wanted, internal medicine.
So now we are fully fledged in your commitment to internal medicine residency, right?
Yes, I definitely am.
That is good. That is good. So I also see that you have extensive research background, and I was so impressed with one of your research on fertility and conception post kidney transplant, and it was published recently, right?
Yes, that's right.
That is nice. That is nice. So can you elaborate a little bit about it?
Sure. The project, recently, when I rotated teaching, I first did college where I came across a beautiful professor, and he was actually working with several research that we.
Farah, can you turn off the video? We'll turn off the video, then the bandwidth of the internet will be good. So you can turn off the video. I think we can do it on audio. Guys, can you hear her now? Is the voice clear?
Hello, can you hear me?
I think it's a little bit better than before.
Wait, let me fix my connection. Just give me 2 minutes.
Okay, no problem. So while she's fixing her connection, what I'm trying to do is just not to ask the question that I asked the previous candidate, so that we will learn more about it, one. And secondly, you changed the idea of the interview. Early, it was more friendly and approachable, and sometimes you may not get that chance. Sometimes some program director may be a bit rigid and more concerned about the CV. So the first one was a friendly approach of interviewing the candidate, and the second one is going to be more about the extraction of the
Hello, everyone. Can you hear me now?
Yes, we can hear you.
Okay. Please let me know if my voice goes out again.
Okay, your voice is good now. I was trying to explain to the audience that the first one was the more friendly approach. The second one is more about extracting what has been written in the CV, and it's going to be more formal and a bit rigid. So you were talking about your research paper on fertility, post-conception, and in the transplant, right?
Yes, I was. Yes, I said this was actually a research project that I worked with along with my because I'm not sure if you guys heard that part, but when I started rotating internal medicine in Soba Teaching Hospital, I actually started by rotating through the nephrology unit, and that is where I met a beautiful professor by the name of Dr. Alaa Hassan, and he was actually going about and doing a lot of researches during that time in the department, and I was actually very excited to join, and those research projects in specific actually interested me, so I went about and worked on them along with them.
It's good that the program that you're applying is also a university program. So we extensively work on research and publication and post-graduation fellowship. So you'll love it here. And I also see in your CV that you are currently a peer reviewer for a journal, right? What does a peer reviewer do in a journal?
Okay. So basically you volunteer to become a peer reviewer at any specific journal, and then you start getting emails which invite you to actually go about and read potential papers that are being submitted to the journal for publication, and you read those papers and give your in your perspectives what you think the paper was good at, was deficient at, is it good for publishing, or does it still need review? So yeah, that's a peer reviewer tasks in a nutshell.
That is good. That is good. I see you are extensively involved in research. Can you sum it up about your clinical experience? Like, what have you been doing apart research and going back to clinical experience?
Okay. Actually, my clinical experience and my research projects have always been going together. Yeah, as I told you, because during my work time at SOBA, rotating in the nephrology unit, that's when I was working at the same time at those projects. My clinical experience is actually, I did my internship, as I said, in my home country, where I rotated in the four major specialties. And then I did this compulsory 1 year of ophthalmology. I also rotated in a tertiary hospital. And then I did my internal medicine rotation, which unfortunately ended in less than 3 months because of the unfortunate situations in my home country. Other than that, I would have still been working on it, obviously.
Sorry to hear about that, but that really shows a good commitment to go on and achieve your dreams. So enough about the CV. Let's talk about something else. Why do you think you will fit in well with our program, or why do you think we should hire you as a candidate here in our hospital?
Okay. I see myself as a very dedicated person. I do what I love with passion, and medicine was my passion since a very young age. Like, since I was young, I've always wanted to do medicine. So I believe that I will be able to, if I was given this opportunity, I will be able to do my maximum. And I do have plans and future goals that that make me really want this residency program and this opportunity. So first of all, I'm dedicated. The second thing is that I'm very passionate about my patients, and I believe that I'm a good fit for internal medicine. I've always been a person that likes to stay around adults and talk more to adults, and sometimes even elderlies, better than they can do with other subgroups. And I see the feedback, like adults also like to talk to me, and I've been able to develop good trust relationships with my patients in those short years of my clinical experience. Another thing is that I'm really dedicated to the field of medicine and growing. I love to teach, and I love doing researches, and I think those two things come greatly in a field such as internal medicine.
That's really, really good. And you have to know that the program that you're applying is a university hospital, so it's going to be a bit busy as compared to other primary care or maybe countryside hospitals. So supposedly you run into an argument or miscommunication with your fellow resident. How would you solve that? Like, tell me, how would you handle yourself in a difficult situation?
I'm a pretty much patient person, so I'll just how I deal with the conflicts is that at the very moment, I would rather to stay silent and let the conflict cool a bit. Okay, let everyone cool a bit, and then I'll definitely try to convey to the other to suppose my senior resident in a very polite way, because definitely he's my senior. If there is perhaps any misunderstanding, or if I was wrong, I would say that, yeah, that's right, I was wrong. Yeah, I guess that's how I will deal with the patient in the situation.
Okay, that's really, really nice. What do you think is the best character or strengths that you have that other candidates might not have?
I think I'm very hardworking, and I'm a very fast learner. I really believe in those two traits in myself. There, up till now, there is nothing that I wanted to achieve that I haven't, and I'm actually I'm a quick learner and quickly adapt, and I can quickly adapt to different situations. So
Yeah, that
yes,
is
these two
because I think
make stand out.
I also see that you got 2 awards and research scholarship and 2 publications and 3 pending publication. That's really impressive. So I think you'll be a good candidate for us. And this is the official end of our interview. If you have any question on your side, feel free to ask, and I'm ready to answer whatever question or concerns you have about our program and as a program director.
I don't have questions. I don't.
No problem. No problem. Thank you. Thank you, Dr. Farah.
Thank you.
Hi, everyone. This is the official end of the interview. I hope everyone enjoyed it. So we are open to comment, suggestion.
So can I start? Thank you so much, Dr. Naod. You did great as a program director. Good acting. Farah and both of you, you did your best, which is great. I think you are excellent candidate with your comparing your presentation, or you presented yourself well. We started to have a little bit of technical issues with Farah in the beginning. But that can be expected. So I advise usually when you have the connection issue or the computer, you will have plan B, or you have another way. You have a desktop, you have a laptop, or you have your phone ready just in case there is issues. So, but I like your answers, both of you. There is always room for improvement for both of you. I noticed if you answer your questions straightforward, yes, no, or give the elaborate answer, I think you should think about dividing it into parts. So one part of the body part is the right answer for the question, but add something to it, like an introduction to the question, or add something to it at the end so that you can lead the person in front of you to ask you more questions in the area that you are comfortable with. Farah, you did some research work. So when you are expressing or answering question about your qualities, I think would be great when you add something of interest to the, in this case, program director, to ask you more about what you did as a writer, as a publisher, or whatever. So you give them some you call it a date or some sentence where you end to answer this a short indication that you love research, especially when you work in this place or with physician or with professor. So this is the part where you want to play with your answer. So you want to convince them with your answer to the question that they ask, but at the same time, at the end of your answer, them to area where you want to tell more about yourself, about your experience, about your passion, about whatever you want to discuss more or to give more details. And it may not fit to put all the information in your answer for that part, but you can give just a sentence or something to indicate that you are opening the door for them to ask more questions, something like that. One area for improvement is the smile, and we cannot underestimate the power of smiling when you answer the question. This has a very effective method when you are smiling at your answer. I noticed, Farah, you use some of your hands when you answer a question, which is good. Dana, your camera was a little bit short, so if you can show some part of your body where, or you use your hand where the camera can capture your body language, including your hand, that might be an option also to improve. All these are just areas you can see when you look at this recording back, see how you did and what areas why you can improve on. Any other want to add your feedback? Please go ahead. Thank you.
Thank you, Dr. Nader, for the fruitful feedback. I'll work on all the tips you gave us, inshallah.
So, and you have time. So, I watched the football World Cup, and one of the statement that was made by one of the players is that we come prepared for this World Cup for them. So you have time to prepare well for the interview. So use it and try to repeat yourself, try to improve on. And the more you do it, the better you will be. Specifically, like Farah, your answers, you have the answer, but I noticed your sentences will be like you start with 2, 3 words, and then you start the sentence again, which is you have the answer, but you did not practice it well. It's not gonna come smoothly and solve the whole answer. So this is when you are prepared, you practice, and then it will come as very handy. You don't have to think and talk and process while you are in the front of the camera or the interviewer, because you already know the material, already know the answer. It's just how you can make it smooth. And see, this is similar to acting, like when you look at these movies, they take the snippet of part of the movie, but they repeat that once, 2 times, maybe 10 times until the perfect the part, and then they add it to the sequence of the movie. So I want you to practice. The more you practice all your answers, I think the better you will be fluent when you get your answers. But thank you. Sorry, I thought so.
Thank you. That is so right. You are so right. Now, looking back to it, I do recognize actually I was stuttering a bit. And yeah, I should practice more, definitely. Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Actually, it's about the CV. So if I had to do observership in a clinic, but at the same time I was allowed to do physical examination. I mean, the doctor allowed me to do physical examination. So what should I put? Is it elective or is it training or what should I put in the ERAS application?
I'm not sure. Usually, if it's an elective, it's an official part. You go to a medical school. Here, they have elective where they have the course. And then when you do that course, they can give you a certificate or something like that. You can prove that you already went through this part of elective. But if it's just you are shadowing and then the physician told you, hey, you can listen to the ones or tell me what you think about this abdomen, examine the abdomen and find something like that. I think this is part of the shadowing or the clinical experience as an extension or what like you just have clinical experience as an observer. Yes, they can let you do some of these activities. I wouldn't put it in a written format that you have like elective part because you may get in trouble for that if it's not an official part. And then the other thing is when you do extension, if you can ask the doctor who did the extension with them, if they can have a copy of the letter so they can mention that you saw patients or you did that and it just will show some light, will shed some light on your experiences in the area. If that makes sense. Thank you.
Thank you. Thank you, Dr. Nader.
Hello, Dr. Nader.
Hello.
Yes, thank you, Dr. Nader, and thank you all guys for such an informative presentation and interview questions. But I would like to ask about the difference between externship, observership, and shadowing. You hear me?
Yes, we can hear you. I think the internet went down. So usually shadowing is just, I don't know, correct me if I'm wrong, the rest of the group. Shadowing is for a very short period of time, usually 2 to 3 days. That's the clinical explanation. And observership is usually uninterrupted up to a month, or it can be done up to 5 months if you do it in a private clinic. But externship, I think you have to take step 3 to do externship. So observership is you observe the doctor. You are allowed to take history. I'm not sure about the physical examination. But if you are kind enough, if your mentor is kind enough, sometimes they allow you to do physical examination. But by definition, what they say is shadowing and observership doesn't involve touching the patient. But there are other states which allows you to do observership and do physical examination under direct supervision of the doctor who sponsored you. But externship is you will be hired as an employee because you have done step 1, step 2, and you have also taken step 3. They kind of like hire you, which means that you are part of the team. It's more, so in terms of gravity, if you done externship, it is very appreciated and you are lucky. If not, you can do observership and sometimes you can do shadowing. So instead of submitting a blank CV, if you did shadowing or observership, you can put it. But if you did externship, that puts more gravity into your clinical experience. But it depends by state by state. Some states allow you to do physical examination while you are doing observership, whereas other states exclusively tell you not to touch the patient or not even to give advice to patient within a hospital because you are not part of the team. So generally, shadowing, short period of time, observership a bit longer, up to a month or 2 months. Externship, they hire you as an employee.
Thank you, Dr. Naod. But my question is, now I'm doing rotation with an agency. They put the term externship for what I'm doing, while I'm not taking step 3. I'm just ASFMG certified, and they title it with externship.
If I could just come in and answer, if that's okay. So the externship part, it depends on the hospital. So some hospitals, they say you have to have at least step 1 in order to do an externship with them. Some hospitals require step 1 and step 2. And just like Dr. Naod said, some require step 3 as well. Some hospitals don't even require you to do any steps. So you can do an externship without any of the exams, but it depends on the hospital. Now, also, whether you're going to examine patients or take a history from them, it also depends on the hospital too and the doctor that you're with. Some doctors are comfortable for you to take a full history, do an examination, and present the cases. Other places, they're not so friendly. So you'll be more of just an observership, as in you'll just observe them as they examine the patient, talk to the patient and everything, but you won't have any input.
So nobody can argue me about if I write down that I do observership while I'm taking care of patient and stuff.
So like we said earlier, so an observership legally, it's you're literally just observing. You're not playing any part in the medical progress for the patient, so you're not really involved in their healthcare. That's for your observership, but the externship is where you're allowed to talk to the patients, you're allowed to examine them, and then depending on the place, they could also let you use the ECR system in the hospital just to put information under supervision if they approve it.
Thank you so much. Thank you.
That's okay, no problem.
But if they were kind enough to put it as externship, you have to back it up in the letter of recommendation. So whoever said that what you are doing now is considered externship, try to ask kindly to include or to mention that in the letter of recommendation that they are writing. So you'll be having a good backup plan saying that, well, I did this, but I was allowed to do this, and the proof is there in the letter of recommendation. So that's a safe way to take.
Okay, thank you so much.
Do we have other questions regarding the presentation or other one? Dr. Sabah, go ahead.
Thank you so much, Doctor. Actually, my question is, it's not exactly related to this presentation. By the way, thank you, everybody. It was a very educational presentation. I actually wanted to discuss about my project. I can ask this question a little later on. I wasn't sure if there's going to be a project update session today.
There will be a project update session after the questions regarding this session or other are addressed. Then I think Dr. Nadia is back. You can answer that question.
Okay, I'm sorry. I'll just ask that question later then.
Sorry.
I can ask this question later then. I'm sorry, I wasn't aware. I wasn't sure about it.
Dr. Wali, go ahead.
Yes, thank you so much, everybody, for this nice and very informative presentation. I appreciate what you are doing for us. My question is, I think it's a good idea to ask at the end of the interview to ask the director regarding his advice or his recommendation, or let him to advise you. Is it or is not a good idea to ask these questions at the end of the interview? It looks like seems kind of not legitimate or not like nice, or it's good. You can ask this kind of like for advice from him.
So if you ask me, I would say no. And reason behind that, you want to show yourself as a confident candidate. Although you might not be the greatest in the group, let's say if you are with other candidates, but I want you to show yourself as perfect one who outpass all these other candidates. And you should be unique for them to remember you and to select you for their group or ranking system. So you have to be very confident in your answers. You have to be, as we mentioned, prepared. And if you have to ask questions, And I think you have to prepare 2 specific questions for each program. So one of the things that show your interest is I looked, you can mention that you look at their website or you talk to their residents or whatever information you obtain as a background for. So you would say, I saw that your recent board exam passing with your resume is 100%, which is good. So do you offer some review courses or help with that? Something like you want to look not only for the position right that you are entering, like step on first year, you want to show them that you are thinking not only about the residency, but how you can pass the board exam. So your eye is far away rather than only you want to put your foot in the door. That question will give them some aspect. That means you did some homework, you look at their website, you ask their residents, you obtain some information. So you are interested in the program more than the other candidates in your class or interview sessions. Number 2, you show them that you are thinking ahead. So you have a 3-year plan or 5-year plan, or something like that. And you are interested in passing that on. So you will be a good candidate for them the way you think it. This is just an example. You can think about other examples, like I look at your percentage of fellowship acceptance, and I see that in your program there are a lot of fellows in cardiology, for example. And then you can talk and ask the question about if I want to go to cardiology, do you have mentors so that they can help guide research work? So you show them that you look at the program, you identify areas that of quality for that program, and then your interest, what you are looking for, and what service or what help they can offer in that program. That's the academic program. If it's a community program, then you will not focus on the research part, you will focus on the service or helping others part, something like that. So we want to ask questions, but when you ask the question, it's an opportunity for you to show the program that you did some homework. You looked at the program weaknesses or strength, and what attracts you to that program, what you can match your quality with the quality of that program, so that you can be a good fit for that program. If you don't match, let's say, but you're still interested in that program, then you can, after the match, you can contact the program director and mention something about your interview, that you were interested in the program and you had a good interview with them, and you plan to apply next year. What are the areas that you think you might be focusing on to improve, something like that. So they will remember you, they will give you an advice like Farah, you did not do a lot of research, you did not do whatever, some area for your clinical extensive or clinical training in EMR, something they can guide you as far as what's the next step. And this happened to one of the candidates of one of our fellows in this program first class. She had an interview and she did not match. So she approached the program director and, hey, this is what I remember this interview. What else can I do to improve my application? Something like that. Another applicant also tried to contact with the program after the first attempt and try to get in connection with the program director with the platform, so they can recognize him in the next something like that. So the short answer is no, don't ask this question. You can ask the faculty if you are comfortable with them. You can ask them, how do you think I did, or something like that, and conversation wise. But program director, I think you should present yourself with some confidence.
Yeah, thank you. Thank you so much, Dr. Nadir, for clarification.
Sure. Go ahead. Farah, go ahead. You have a question?
Yes, I have a question. I'm not sure about the specific information, but I heard that community programs don't really, let's not say care, but they don't really give too much weight to research work as much as university programs. I'm not sure about that. So would it actually affect my application if I have, for example, 3 publications or maybe just 1 publication but extensive research work, but I'm still applying to a community program? Yeah, would that raise a bit of question, or maybe would the program directors have be not really comfortable with my application, perhaps thinking that I probably applied to university programs as well?
So the answer for that is some of the community programs, yes, they don't focus on the research as much, but it qualify you as a good candidate that you can do your homework, you can work with teams, because most of the time for the application to get to the finish line, most of the time you are not going to do it by yourself. It's not a one person job most of the time. So you will work in teams. Will be there. You will show your best and goal-oriented this quality that to work with teams, and they want you to finish the job. So you can take this aspect of the research part to highlight your quality in this area. But some community programs, they encourage their presidents to do some research work. They don't offer, or they don't have enough support for research in academic programs. They have some funding, they have some mentors, they have researchers or postgraduates. So there are some resources for the residents to get engaged in research activity. If you want, you can get as much as you want in the research. So they have the resources and they encourage you. In community programs, they don't have the resource. Some of them might encourage you, some might not. So when you put it in the resume, it's not going to harm you. When you ask during the interview, then you can elaborate that I'm interested in whatever areas or specialties. And what's your 5-year, 10-year plan? Are you planning to stay in the area? Let's say in a community program, you want to search out the area. If you have a family and that area is a family oriented, or there are good schools for the kids and so forth. So you might mention that I looked at your area, I looked at your program, and I found that it's suitable for me. I'm gonna move and live there for quite some time, something like that. These programs will want to have you for a long period. So the more you focus on that area, the better your chance to get accepted. They don't want you to spend the 3 years and leave impossible. Thanks.
Okay, I understand. Thank you.
You're welcome. Okay, go ahead, Tanya.
Hello, everyone. Hi, Dr. Nadir. Thank you for everyone who presented today. It was really great. Dr. Nader, I do have a question about a letter of recommendation. One of the questions that when you submit your request to the doctor is that, do you want to waive your right to read the letter? I want your advice regarding this. Some people are saying that you don't want to, because you're going to be biased if you read the letter. So what is your advice?
My advice is you don't ask for reviewing, or you waive your right to look at the letter. And the idea is that when you do that, some of the program will look at it as a way of confidence from your side that you did your work, and your supervisor or whomever you work with will write a good letter for you. And it depends on your relationship with that person. So if you did a good job and you know that person and you ask them for a letter of recommendation,
Can you guys hear Dr. Nadir's voice?
No, actually, we lost him. I believe it's connection.
He was just trying to explain. So basically what I think is, if the person who is going to write the letter of recommendation for you is kind enough, they always send you a draft, then you can waive it and attach it. But if you have a feeling that that letter of recommendation might have something a bit negative, or if you don't necessarily trust that letter of recommendation, sometimes it's good to see it. So the best way, as Dr. Nadir was explaining, it depends on what kind of relationship you have with the person who is writing the letter of recommendation for you. If you are dead serious and you trust them, it's better to waive it. But if you, let's say, work in a clinic for 1 week or 2 weeks, and if they don't personally know you, if they don't even remember your name, sometimes it could be a very risky business to attach it without seeing it. I think Dr. Nadir is back.
Exactly. So if you have a good relationship with the mentor or the person that you work with, I think they can write a good letter and you waive your right to look at that letter.
Thank you, Dr. Nadir. Any more questions?
Thank you, Dr. Nadir. And is it, so it's okay for me to ask for it to be sent to my email? Is that something I can request?
Definitely you can request that. So you can have a copy of that. If they prefer to have copy sent to you, that's volunteer. If they say, no, you already waived your right, then
thank you so much, Dr. Nadir. I appreciate it.
You're welcome. Any more questions? I think Sarah, go ahead.
Hello, everyone. I have a question regarding clinical experience. If I have a large clinical gap for years, so how can I explain that during interview or CV to be add benefits to me?
So this is a personal area for each one of us might be different from like people in Sudan, for example. In the past 2 years, there is a war or whatever instability. In other places, you might have started to establish new family, for example, or you come to this country, you are working on your board exams, so you may take some time, or you may be working on research. So as long as you show them that that gap you were having some reasonable reasons to share. And then what did you do if you were not in the clinical business? Let's say you start with a family, you raise your kids. That's acceptable for most of the programs, but they don't want you to be left out of the clinical and then come right away to the residency. They want you to show them that you did 3, 4, 5 extensive or some observership, some working in the clinical area, so volunteering in clinics or something that you still close enough with the clinical part to know how to use the EMR, you know the system, you know how to take history. You are kept yourself up to date as far as the knowledge, and so you are taking step 3. Something that proves to them that although you spend some time away, but now you are working hard. But you can see spot that everyone is trying to get. This is why they want a couple of the 5 years recently. It's just because the longer you are away from medicine, you be rusty, and they don't want you to be learning the basics when you start, because when you start into life, they expect you to take the history, find and examine the order the X-ray or lab, and put the plan, and next day put whatever. So it's gonna be fast paced. While you are learning, you are focusing on certain things, not the basic things that you learn in medical school for example. Exactly.
Thank you, Dr. Nadir.
Thank you. So we can, if no question, go to the next part of the
project update. Yes.
Project, yeah, updates. So I think Farah, you have a question, or you want to take us if you're still there?
Hello?
Hello.
Yes, Assalamu alaikum, Dr. Nadir.
Alaikum salam.
Sorry, did you ask someone else? I didn't hear you. I
Go ahead.
apologize.
No, go ahead, Nafisa. And Farah was, I think, she's gonna be after you. So go ahead.
All right. Okay.
Nafisa.
Thank you. All right. Thank you, Dr. Nadir. Thank you, everyone. Thank you for all the presenters today. Thank you for the Dr. Naod and the interviewer today. It's like amazing. Thank you, everyone. So I would like just to talk about our blood pressure app. So we are in the finalizing phase 1. We finished about like more than 90% of the app. Alhamdulillah. We're so happy and excited about it. We worked very hard on it. I would like to thank Dr. Ahmed. She did a great job. If it was not with us, I'm not sure if we'll be able to finish it. So thank you so much, Dr. Ahmed. Thank you for all of my group. So I'm not sure if Dr. Ahmed, she's here and she would like to just walk us through the app so you can see and give us at least some advice what to do before we finish it.
Thank you so much, Dr. Nafisa, and thank you so much for being such a great co-leader. First of all, I would like to thank Dr. Nadir for introducing us to this great platform. I'm so proud of myself. I never thought in my life that I would be able to develop applications. I'm so proud and I'm bragging about this actually. And I believe that all my team members are bragging about this as well. So let me share with you our exciting application. Can you see my screen?
Yes, Dr. Ahmed.
Okay. So I'm going to put my phone in the test mode so you can see our work. This is the background. Okay, just a minute. So this is the first screen, and we give it the name of pressure care. Credits to Dr. Nafisa for choosing this great name. So this is basically our homepage. Nothing special about the design. Maybe we'll improve it later, but we want to keep everything simple at the beginning. So now I'm going to go to the first page, which is about this app. And now we're just giving a brief description to the application and what are the additional features that are available and how this application is going to help hypertensive patients. Going back to the homepage, and then we have the My Profile page, where there are the basic information that the patient or the user is going to enter. So here I added my name, and the user is going to add the date of birth as well. And then the medical history, like we put the most common comorbidities like diabetes, high cholesterol, heart disease, and kidney disease. Of course, we can add more. And of course, I want to listen to your constructive feedback at the end. And also, we added some basic questions like, do you smoke or do you drink alcohol, with a switch option like this. It says yes or no. And then here we have two buttons for selecting the medication and selecting the dose. And from here, I want to thank Dr. Hina and Dr. Noura for adding an extensive list of the most commonly used antihypertensive medications. They did really a great job collecting all these medications and adding the dosages for all the medicines that are commonly used to control hypertension. So let me get back to show you how it works. So for example, I'm taking amlodipine. I'm going to choose amlodipine. And here the list automatically is going to be personalized to the dose, giving us the dosages that are specific only to amlodipine. So if I clicked on select dosages, as you can see, it shows it the dosages for amlodipine. Getting back, I'm going to choose another antihypertensive medication, maybe let's say candesartan. And as you can see, it shows the doses for candesartan. Okay, so I'm going to get back to the home page. So here is the main page, which is the blood pressure readings. It was the most challenging page actually to make, but alhamdulillah, we're able to make something at the end. It's a little bit slow. Okay, so what we were able to add is to add the readings for a week. We were not able to add more than a week, but the readings are going to be stored in the application itself using a tiny database inside the app for a duration of 1 week. So here I intentionally added a very high systolic blood pressure reading and a very low diastolic blood pressure reading on Monday, because I wanted to show you something when we go to the summary page. So here the data summary. The data summary page is going to summarize all the blood pressure readings that were recorded over a week and put it in a table format. And also it's going to summarize the patient's data like the name, age, and date of birth. So let me go to the data summary page. Okay, as you can see here, it shows my name. Okay, it shows my name, my date of birth, the medication I'm taking, which is the last one I chose, candesartan, and the dose 32 milligrams. And as you can see here, it's summarized in a table, like for Monday through up to Sunday. So as you can see, we were able also to add a feature that tells us if the blood pressure is high, the text is automatically going to turn into red. If it's very low reading, it's going to turn into blue. And if it's something normal, it's going to stay green. So I added this color coding to show us like how to interpret the colors. So another interesting feature is the screenshot and share. Let me show you how it works. It's going to make a screenshot and then automatically opens the share, so you can share it to through social media or through Gmail to a family member or a healthcare provider. So if I clicked on that, it's taking a screenshot and then opens the sharing. So for example, I want to share it to my WhatsApp. I'm going to share it to myself to show you how it works. Okay. So as you can see, it shares the screen itself. And along with that, it also shares my name, my date of birth, the medication I'm taking, and the dose in a message. So as you can see, now it's shared like this. And also, if it's shared through the Gmail, it's going to be shared the same way, like the screen, the image, and then the message at the end. So let me get back. So here, if I want to add a new reading, I'm going to click on the button and going to the blood pressure reading page. And say, for example, I added the reading for Monday. I want to add the reading for Tuesday. So it's going to get me back to the page so I can add the readings for Tuesday as well. Okay, let me get back to the home page to show you other features. So here we have the health information guide. We need to work a little bit on the design of this page, but I want to show you the main features. Here we added like the most common information, important health guide information that we think patients need to understand, hypertensive patients. So if I clicked on healthy weight, it's going to take me to a page that is designed by Dr. Nafisa. I would like to thank Dr. Nafisa for designing great images for the health guide information using Canva. She did a great job doing this. So here there are two buttons at the bottom of the screen. As you can see, this button, it's taking us back to the to this page. And the other one, the next button is going to take us to the next health guide information. As you can see, very beautiful images. Okay. Let me get back to the home page. So here, the next one is medication information. So it's not yet completed, so I'm not going to review this. Here we have the chart review that I showed you, the summary page. It's the same. It's going to show us the readings over a week. And then my treatment plan is also not yet done. Here we have the disclaimer. It just shows that this is not going to replace professional healthcare provider advice. It's only like for knowledge and health maintenance. And the last thing is the copyright page. I'm also not going to review this because it's not yet complete. So we did about 90% of it. And again, I would like to thank Dr. Nader for the great opportunities. I would like to thank Dr. Nafisa for helping me with this and all the great team members who did a very hard work in a short amount of time to come up with this. And thank you everyone for listening. Please, we need your constructive feedback. If you think there is something we need to add or we need to delete, please let us know. Thank you so much for your listening.
Thank you,
Amazing.
Dr. Ahmed. Thank you so much. We'd like just to clarify that we would like also to thank Dr. Namarik. She's the one who did the medication. Just to add to the one that you mentioned. Thank you so much.
Yeah, thank you so much, Dr. Namarik. Sorry, I forgot to mention Dr. Namarik, but actually, yeah, she did a great job. Thank you so much to all team members as well.
Excellent. Amazing. Also, good job, guys. Very impressive. Any other feedback? Thank you for sharing this progress, and hopefully soon the app will be complete. And so my suggestion is because other fellows might be interested, and I think we spoke about how to involve other people. So if any of the fellows interested, what we can do is we can ask them to join the team who is working on this app and develop a marketing plan. So let's say I'm going to just partner, for example, or Magic, if they are interested in joining this effort and this team, they can contact Nafisa or Ahmed or the team leader, and then say, hey, I'm interested because they came late. You don't want or you don't expect them to get into the coding system, and so if they have ability to do that, that's fine. If they have feedback, that's fine. But my suggestion is to involve them on how they can start building what we call like an app version, speaking to their other friends, family, doctors who are in the medical field or who are like maybe in this case hypertension medication, so that when we establish this app, some people who can try it and give us reviews or feedback at that stage. So from now we can start preparing for the launch of this program when you upload it to Google Store, for example. So from day one, you can expect a huge number of people because you already start from now until that point, preparing and collecting or inviting or reaching out for customers or for can look at app, give you feedback, and maybe you can reach from first week threshold 50 or 100 persons looking at the app. If that makes sense. Thank you.
Also, Dr. Nader would like just to add that we're gonna have also an Arabic version and a Spanish version, and we already have 2 candidates for that.
So we have another, so you can divide it into another team leader. Use the team that's working in Arabic session or team leader for the French session. And again, you can involve as many of the fellows in this project so they can talk about it, they can put it in the CV, and they can help develop this project to the maximum goal. We can work on the version, the basic version, the same way we just saw here, finishing the 3 areas that are not finished, and then see if it's complete. We can go ahead with the uploading to the store and so forth. in the meantime, we can ask the other language experts in other fields, Spanish, to help with changes. But thank you. That's a great insight for sharing and that.
You're welcome. Thank you to you, Dr. Nader, for this opportunity. Thank you so much.
You're welcome. Good job. Great. I'm very glad.
Thank you so much, Dr. Nader. I think Dua Muhammad asked a question on the chat. She said that if the patient is using more than one medication, is there an option for that in your app? I think this is a great question. I think I will consider adding this. Yes, like some patients take more than one medication, so it shouldn't be just like one option. There should be always an option to add other medications. So thank you so much, Dr. Dua, for the suggestion.
And also I would like to add something to that, Dr. Nader. Me and Dr. Amal, we was discussing about, we added feature in the app that if the patient we don't have, like, for example, alarm or notification, that's something we can work on in the future. But we put like the patient, if he have like an appointment, he can select the specialty and the date and time of the appointment beside the other comorbidities. So my just idea regarding that, I would like to make the patient like visit our app more often, and like, because it's a place that he can put all the medication. It's a place that he can go back to see his appointment, and the place that he can share his blood pressure information. So Dr. Amashi suggests that is not, if we can take out, for example, the appointment time and the specialty and stuff like that, since it's not relative to our app. So I would like just to hear your point of view regarding this. Thank you, Dr. Nader.
Excellent. Thanks. So the idea itself is great. So sometimes what we think is like features. So my thinking is you go small and then you go slowly and then build up additional features. So if it's like the geriatric approach, so we give low dose for blood pressure and then go up a little bit slowly and you add more medication. My approach is so when you just show up, and then you think about how to develop extra features. It's a great idea to add the appointment. If we can add it as a new feature as we go on, let's say version 2 will be added feature of adding the appointment. And then both with other features, let's say, I'm not sure if you're gonna do it in this or maybe version 3 is alarm every day that you did not add your blood pressure or did you take your medication? Yes, something like that. So all these are user-friendly features, and we can see how it applies to the users, but we don't have to put all stuff with the first version. The first version is like a demo, like I mean, showed up. If we complete that, it's like the package. If we complete the package, and then we can think about version 2, what can we add? Version 3, what we can add? And it's going to be a product in progress. So it's like the iPhone, the first iPhone, when it came, it was very primitive, but at that time, it was awesome for everyone. A camera here, whatever. Although the features are not all there, but for the user, they are user friendly. They can do like use their finger to move things around, something like that. And then they improve with the camera, the capacity of the size, the memory, or with the many apps. And each version, it will come with additional features, the size of the screen, by the So it's just every time you want to add complex features, think about it ahead, but don't add it right away. You can work on another version where we can test and then add it in the version 2. The third version, fourth version. If that makes sense.
Yes, I got it. Thank you, Dr. Matis. Definitely we will do that. We still have one pair of the group that they didn't finish task, so that is going to be their task as well. So we'll definitely, every time we just add more feature, and since the blood pressure is very common, we would like to make our group our app, it's like just something handy and something all the time the patient visits and have all the information that he needs in one place. And also regarding the copyright and disclaimer in the first page for the app, we would like to suggest that I was discussed with Dr. Ahmed, if all the app group, they can do the same thing, so we can link into our fellowship programs to make it that something unique and special to our fellowship. So all of us, we're gonna have the same thing in all the apps. That's okay, good. That's perfect. So if not, Dr. Amal want to add anything, and Dr. Naod, he one of the very active member in our group, and I really appreciate his support as well. So if they're not the one to add any comment, I would like to ask something different, not about the app.
You can go ahead.
Okay, so Dr. Mario would like to ask about if there is a way that to create a website or an app, and which one is secure when it coming regarding the entering patient information for example, patient chart or electronic medical system, but in a simple way. It's not expanded one, is not the one we share information with other provider, is not the one that you can receive app from labs. It's just basically a secure place to save information about, let's say, one clinic.
Sorry, I didn't get the first part of the question.
So we work in a free clinic, and this free clinic is basically just a place that it's a charity place, and we do a free clinic on it. I would like to have a secure electronic medical system just for this clinic. So it's going to be something simple. It's not something that you would like the big electronic medical system to link it with other providers or to link it with laboratory, so we can receive patient labs. It's just something to have the provider work in the clinic to access that place and enter the patient information, so that it can be like a website or an app. I would like to ask if the app something secure and safe to save the patient information.
So if the question is to develop a new app, it can take some time to make it. And security is the question. To create some information on the screen itself or Google Sheet. Medical problems, you have the problems, you can just add to the medical problems as you go along. So the solution is there if you're looking for just a quick solution. And the only issue with that, Google Sheet or Excel is not secure. Protected, and the data might be breached. So this is the only caveat to the problem of using a standalone. To solve it, there are some EMR that are HIPAA protected, and you can pay $100, I think, $150 per month per provider. So if your organization is willing to pay something like that, and then the cost will be divided, and it's not gonna, it's gonna be minimal cost to each one. So instead of going, because the solution is there, but the limitation is the feedback of the security.
Thank you. Thank you so much, Dr. Nader. Thank you. I have like something to add to this, but I'm gonna take a look at it first before I talk to you about it. But thank you so much. Yeah, I got the point. Thank you so much.
Thank you, Dr. Nader. So I actually wanted to ask about the project I've been working on with my team. It's about it's a gap study on IMGs regarding elder abuse, and after discussing it with you and on your recommendation, we decided to go with the we decided to we decided to go with the part where we prepare a seminar for the IMGs, preferably the fellow, and we're targeting the fellows now in the program, because it's easier for us to, because it's easier to have all of us in one place and be able to conduct a seminar and then have our questionnaires filled out again by them, and then we can have a comparative study. So we had a discussion in the group in the last few. We have been discussing in the past few weeks how to go about everything, and we have we've finally made a decision on how to. We have somewhat of a proposal for the seminar and how we want to go forward with it. So I was hoping if we could get in touch with you, and if we could get you to take a look at the proposal, and whatever recommendations you have for that, we would really appreciate that. And also we were hoping if we could conduct a seminar, if you could allow us any time slot that might be available, so that we can have that seminar with all the fellows or whoever can join during that time. So that we're able to complete our study during in the given time.
We can shoot for maybe you can plan in 2 or 3 weeks. You can do something. So if you can give me a call later, maybe we can talk about how we can arrange something like that.
Okay. Thank you very much. Thank you so much, Doctor. I look forward to your call.
No problem. Thanks. Anyone else? So if there is no more questions, I'd like to thank all the presenters from today. And thank you, Dr. Naod and your team. Thank you for the update, all the other fellows. Thanks for your attendance, the other fellows who attended today. And thanks for those who will come over later to and recording. I wish you all the best. Assalamu alaikum. Let's see you next week.
Thank you so much, Dr. Nader. Have a good one.
Have a good one.